All right, so it's 2:01. Good afternoon, everyone. Welcome to the Yale Sleep Seminar Series. My name is Ritika Thapa. I'm one of the faculties here at Yale. Just a few brief announcements before I introduce our today's speaker. Please take a moment to ensure you're muted. In order to receive the CME credit, please see the chat room for instructions. If you have any questions or comments during the presentations, please use the chat room or take the opportunity to unmute yourself, and I will also moderate the session. The recorded version will be available on YouTube a few weeks after the presentation. And today, I have the pleasure of introducing Dr. Lynn Marie Trotti. Dr. Trotti received her medical degree from Baylor College of Medicine. She completed her neurology residency at Emory, where she was also a chief resident, and her sleep medicine fellowship as well from there. She's currently an associate professor of neurology with tenure and an associate professor of pediatrics at Emory. She's also the associate fellowship director of sleep medicine there. Her research has primarily focused in the pathophysiology and treatment of the central hypersomnolence disorder, and she performs clinical trials with functional neuroimaging to better characterize these disorders and the response to treatment, and also has long-standing interest in sleep and movement disorders. She has received many awards, is a recipient of several grants, including from the NIH, and has authored over 100 publications. She has also lectured nationally and internationally on various topics, focusing on central hypersomnia and movement disorders, to name a few. Dr. Trotti has also held leadership position in many national societies and is very involved in faculty development programs in our institution, and has also served on the editorial board of many organizations and has multiple media appearances, including in the New York Times. Thank you so much for being with us today. And without further delay, I would like to hand it over to you to share your expertise on idiopathic hypersomnia. I think you're muted. Dr. Trotti. You're muted, Dr. Trotti. There you go, I think.
Okay, good. It wouldn't let me unmute myself. Sorry about that. Thank you for that lovely introduction. That was really nice. And thank you so much for having me to talk about one of my favorite topics, which indeed is idiopathic hypersomnia. So a couple of disclosures before we go. I don't have any financial relationships to disclose. I am a member of the board of the AASM, so please know that I'm here as a private citizen, so any opinions I express are my own, not necessarily having anything to do with the board. And also, I will be discussing off-label use of approved medications, and actually some unapproved medications as well. So just to set the stage, for students and others on the Zoom who may not be as familiar with idiopathic hypersomnia, idiopathic hypersomnia is one of the central disorders of hypersomnolence, so a group of sleep disorders that are presumed to be neurologically based, where the primary manifestation is excessive daytime sleepiness. So in order to have idiopathic hypersomnia, you have to have excessive daytime sleepiness, and it has to occur in the setting of either normal sleep durations at night or long sleep durations at night. There are a number of other symptoms that are considered classic. They're not mandatory for the diagnosis, but if you see them, it helps you get in the right direction of diagnosing idiopathic hypersomnia. Their absence doesn't rule it out. One such classic symptom is very severe, very pronounced sleep inertia. So sleep inertia is the normal physiologic state between being asleep and being awake. But in people with idiopathic hypersomnia, that transition from sleep to wake can be very prolonged. It can be very, very difficult for people to wake up, often needing multiple alarms, often needing another human being to help wake them up. It can take, instead of taking seconds to minutes to get through sleep inertia, it can take hours to get through sleep inertia for people with IH. And relatedly, people with IH tend to take very long naps, and then they wake up feeling worse than before they took the nap. There are other symptoms that are pretty common in people who have idiopathic hypersomnia that definitely contribute to the burden of disease, but they are pretty nonspecific. You see them in lots of other disorders as well. And these are things like cognitive dysfunction, brain fog, and fatigue. So the title of my talk was ambitiously What's New for 2024. What's really exciting about IH right now is there is a lot of work being done. And so unlike it used to be back when I started, where if you wanted to talk about what was new in IH, you needed a pretty big time horizon, a lot happens every year. And so I'm not only going to talk about what's happened in 2024, but I'm really going to try to focus on how has our thinking changed about IH in the last few years. So I'm going to start by talking about diagnosis of IH and diagnostic testing for IH. So of course, the International Classification of Sleep Disorders, third edition, underwent a text revision that came out last summer. The purpose of the enterprise was not to change any diagnostic criteria, but really to think about the text that goes along with the diagnostic criteria. But they were allowed to make adjustments to the criteria sort of for clarification. And so the criteria are here. Everything in black is the old criteria. So sleepiness for 3 months, it's not due to anything else. And then one of 3 objective ways to diagnose it. The changes in the TR version was the PSG MSLT do not show narcolepsy. That idea was in the ICSD-3. It was just a clarification of the language in the text revision. But the change that I think is actually really important in these diagnostic criteria in the text revision is that first one. So the way the ICSD-3 defined excessive sleepiness was daily periods, irrepressible need to sleep, or daytime lapses into sleep. But in both the ICSD-2 and now the ICSD-3 TR, the idea of daytime lapses into drowsiness or sleep is back in the definition of sleepiness. And I think that really matters because when we think about how sleepiness manifests across the central disorders of hypersomnolence, daytime lapses into sleep describes people with narcolepsy type 1 really, really well, right? They may have sudden sleep attacks in the middle of a conversation, in the middle of an activity. People with IH have a constant, irrepressible sleepiness. They are more likely to lapse into drowsiness than have a sudden sleep attack. Someone with IH may be in the middle of a conversation and instead of falling asleep may say, I'm sorry, I got to go lie down, and then go lie down and fall asleep. So I think it helps capture the flavor of how sleepiness is experienced better in people with IH. I want to talk a little bit about the bottom 3 criteria there, which is you need at least one of 3 criteria for objective diagnosis to confirm IH in the right clinical context, having ruled out everything else and so on. So one is a mean sleep latency on the multiple sleep latency test of less than or equal to 8 minutes. One is 24 hours or up to 24 hours in the sleep lab with measured sleep by EEG of at least 11 hours in up to 24. And then the third is at least a week of actigraphy, showing on average at least 11 hours per 24 hours. So in 2021, the AASM updated its protocol for the MSLT. Very much of it is the same, but there are some updates that I think are notable. So one was, instead of just asking people to monitor their sleep through a sleep log with or without actigraphy or for 1 week, that window increased to 2 weeks as the recommended length, as we realize that the effects on the MSLT go back in time further than just the last week before the test. We all know the 2-week washout is really difficult of medications. That's why it is often not done. The data show for MSLTs, really the idea in that is 2 weeks is a good rule of thumb, but think about half-life. 2 weeks is not long enough for some things like fluoxetine that have a very long half-life. And maybe you could get away with a shorter washout for very short half-life drugs. You just have to be careful not to make it so short that then you get a rebound effect. Recommendations for abstaining from caffeine and marijuana are still there, just like they were in the old protocol. but with a little bit more evidence in terms of how long people have to abstain. So there's one study showing effects of caffeine for up to 44 and a half hours. So just abstaining the day of may not be enough. Similarly, relatedly, I guess, with marijuana, we know marijuana can impact the results of the MSLT, but also sudden abstinence from marijuana can also affect the MSLT and causing REM rebound. And so if someone is a chronic user of marijuana, you either need a washout period so you don't get rebound, or they need to stay on a stable known dosing so you can take that into effect. It has a very long half-life. The drug screen can be positive for more than 2 weeks in some people. 6 hours has been the rule of thumb for sleep time on the PSG the night before the MSLT. The protocol update clarifies that's the barest bare minimum. We shouldn't feel great about waking people up after 6 hours, but 6 hours is the absolute minimum. Cell phones are now incorporated in the protocol because they are stimulating. Patients are supposed to be off their phones at least 30 minutes before each nap opportunity. And the language, the text use has changed in a way that I think is very interesting. Instead of telling people and try to fall asleep, the text now say and allow yourself to fall asleep. I want to touch on the 6 hour time and what we know about curtailing night sleep before the MSLT. So this is a paper that just came out in JCSM where they had a lab protocol that woke everyone up at 7 in the morning to start the MSLT, and then decided, let's stop doing that, and made a protocol where people would sleep until they were ready to wake up. And they said, I'm done sleeping for the day. And so then they looked at 290 patients before the change and 290 patients after the change. So sort of a convenience group before and after the change. And what they found was if you let people sleep ad lib, they sleep 48 minutes longer, so almost an hour longer if you don't wake people up at 7 a.m. And really importantly for the diagnostic value of the MSLT, people's mean sleep latency on the MSLT goes up 1.3 minutes when you let them sleep ad lib. And so that it suggests that certainly for some people, waking them up at 7 rather than letting them wake up naturally is going to shorten the MSLT 1.3 minutes on average. And so for some people, it's going to be the difference between a normal mean sleep latency and an abnormally short mean sleep latency. They did not see a statistically significant difference in the number of MSLTs that were positive for narcolepsy with that change. So I think that's a caution for all of us in terms of what is happening when we wake people up artificially before their MSLT. But I think a related question is, ad lib sleep is not just important so that you get an accurate MSLT. Ad lib sleep is important because remember, one of the diagnostic criteria for IH is at least 11 hours of sleep in a 24-hour period. So there's at least 3 different European protocols for how they do a 24-hour study and get that 11 hours of sleep. Here in the US, we need to get paid for the testing that we do, so we can't just do a 32-hour bed rest protocol. But since we have people in the lab almost 24 hours between the PSG and the MSLT, I think there's really opportunities to think about, can we have a protocol for people who we suspect have IH that lets them sleep ad lib to try to get to that 11 hours? And so a number of groups in the US are starting to do this in their clinical labs for the subgroup of people that you suspect to have IH, and we are one of them. This is just in our first year of doing it, what our experience has been. So the way we devised this protocol is when the person gets to the lab, they're the first person the tech hooks up so they can get to bed as early as possible. And then they're allowed to sleep until 10 a.m. If they wake up before 10 a.m., the tech sort of encourages them to go back to sleep, to try to go back to sleep. If they say, no, I'm done, I definitely can't go back to sleep, that's fine. They end the PSG. But if they can try to go back to sleep, they're given until 10 a.m. To try to get as much sleep as possible. The MSLT protocol requires a 5-nap MSLT unless you meet the criteria for narcolepsy by the end of the 4th nap, but it is very, very difficult, at least in our lab, to get 5 naps in if somebody has woken up at 10 a.m. And so just for this hypersomnia protocol, we do a 4-nap MSLT. So in our first year of doing this, 29 of our 70 MSLTs across the enterprise that providers were ordered as this hypersomnia protocol. Like all new protocols, there were some bumps in the road. So of the 29 that were ordered, 23 were done correctly. The ones that were not done correctly, the night tech woke the person up too early because that's what they'd always done. But we kind of got those kinks worked out, and now it's running correctly. Of the people that the hypersomnia protocol was ordered in, but they just woke before 10 and they said, I just can't go back to sleep. That was 7 of the 23. So not really long sleepers when it came to being in the lab. But what you're looking at in the graph is basically what happened to the rest of folks. So 16 of the people had a normal MSLT following this extended opportunity to sleep at night. Half of the people with a normal MSLT met 11-hour total sleep time criteria. And this is over the nighttime sleep plus any sleep they get on the MSLT. Of the IH folks, we had 5 people meet MSLT criteria for IH. One of them also slept at least 11 hours, and we had 2 people meet narcolepsy criteria on the MSLT. Both of them slept more than 11 hours. And so it actually was really pretty common for us to get people sleeping 11 hours in the sleep lab, including a lot of times people who otherwise wouldn't have had a diagnosis. So basically 1 in 3 people who underwent the hypersomnia protocol got a diagnosis of IH based on long sleep durations that they wouldn't have gotten based on their MSLT. So certainly not a standard protocol yet, but I think we need to be exploring things like this if we really want to try to measure 11 hours in the sleep lab. And then, of course, the other way to measure 11 hours is through actigraphy. The ICSD is very clear about the fact that we need more validation studies of actigraphy for the diagnosis of idiopathic hypersomnia. Actigraphy was added because it's not always practical to measure 24 hours in the sleep lab, but there's a lot we don't know about optimizing actigraphy for idiopathic hypersomnia diagnosis. This is a study from several years ago now, from Jesse Cook and David Plant, looking at an actigraph, an ActiWatch Philips device in people who had a clinical diagnosis of idiopathic hypersomnia, some by MSLT, some by total sleep time on PSG. And they looked at, with the actigraphy device, you can change different settings. You can change the threshold for how sensitive it is, how much activity you need to call something wake or sleep. And you can change how many minutes of immobility someone needs to have in order to say they have gone to sleep or they have woken up. And what they did is they looked at every single combination of those 2 settings and then the accuracy with respect to PSG simultaneously measured. And basically the take home is almost every combination on the Philips ActiWatch overestimated total sleep time on actigraphy compared to what they saw on PSG. And here in the blue dot is sort of the default settings of the Philips device. But what is newer is a study that just came out in Sleep this year, where they incorporated actigraphy into a larger protocol of continuous PSG. And so patients came in, had a day, a night, another day, and another night of continuous PSG, and then also had an MSLT. And then some people had another night of PSG and then an MWT. But they looked in this middle, this first night, first day, while people were simultaneously wearing the micromotion logger watch, at the accuracy of different actigraphy algorithms. So they took the raw data from the device and they applied different sleep scoring algorithms to it. And then they looked at the accuracy, and they looked by diagnosis, interestingly enough. So what was frankly a little surprising to me was the IH group measured nighttime sleep really pretty accurately. It really didn't overestimate or underestimate sleep dramatically with any of the algorithms, as opposed to narcolepsy, where where there was an underestimation of nighttime sleep. Daytime does not look so rosy, so a lot of overestimation of daytime sleep in IH patients. And so I think, again, as we're thinking about, well, we're using it across 24 hours in our IH patients, regardless of the algorithm. Some algorithms did better than others, but regardless of the algorithms, we may be overestimating day sleep. We may be okay on nighttime sleep, at least for this device with these algorithms. So that's one of the problems with validating actigraphy for this diagnosis, is there's lots of different algorithms and devices and setting combinations. So separate from diagnosis, where are we at with symptoms? I think we are doing better with some symptoms than others. Sleep inertia is one that can be really problematic. We'll talk about it some when we get to treatments later, but we're doing better, at least, in measuring it. There's now the sleep inertia questionnaire is validated. The Idiopathic Hypersomnia Severity Scale has some sleep inertia questions on it. There's a few different validation studies using reaction time tests to capture sleep inertia in these populations. So we're getting there as far as that symptom goes. Where I think we are not getting so far, where we have a long way to go, is with some of these other symptoms that go along with IH. And so I think one that contributes a lot to our patient's disease burden that we don't always think about or talk about in our clinical trials or in our management is brain fog. What you're looking at here is not data from IH patients. It is actually data from Reddit. And so the authors of this paper scraped an entire week of Reddit posts, and they found any descriptions of brain fog. And so 141 first-person descriptions of brain fog. Half of those people were describing brain fog in the context of an illness, or at least disclosed in their Reddit post they were talking about an illness, and a quarter of those were COVID posts. But what I really like about this paper is they then categorized the brain fog experiences into different groups. And so sometimes when people have brain fog, they mean inattention, distractibility, and poor concentration. And sometimes they mean forgetfulness. And sometimes they mean fatigue. And sometimes they mean cognitive effort. And sometimes they mean things that I think we see less in IH, like dissociative experiences and depersonalization. But it suggests to me, and I think I get this sense clinically as well, brain fog is one of those words that everybody who says it means something different, or at least there are several different constructs within that word. It's like dizziness. Dizziness is a real thing, but there are several different kinds of dizziness depending on what you mean. And I suspect brain fog is going to turn out to be the same thing. There was a great review article published this year in JCSM by Russ Rosenberg and others, looking at brain fog in lots of different disorders and trying to find common themes and good measurement tools, and then figure out how to apply that to the central disorders of hypersomnolence. And they have proposed as a working definition that brain fog is cognitive dysfunction, may or may not be related to the sleepiness, but it presumably reflects an underlying neuronal dysfunction. Presumably it is due to reduced concentration and impaired information processing. And that in turn leads to this lack of clarity and mental thinking. I like this definition. I think it is careful. I think it almost certainly explains some of the brain fog that our patients are experiencing. I'm not sure everybody with IH who describes brain fog is necessarily describing this, but I think this is probably a good subgroup of them. So if we think it's a concentration and an information processing problem, what do we know about that in IH? And I will say not as much as we need to. So this was a review of cognition in central disorders of hypersomnolence, and they looked across a variety of different cognitive subtypes. And if it's yellow, it was impaired in people with IH. If it was white, it was okay. And if it was gray, There aren't any studies that look at it. So most cognitive domains haven't even been studied in IH. The ones that have suggest that alertness and sustained attention and vigilance are impaired. I think that is what we see clinically. But I think the absence of data is as compelling here as the data that we do have. As opposed to people with narcolepsy type 1, nobody's going to argue that we've done all the studies we need to in narcolepsy type 1, but at least cognition has been addressed a little bit more globally. And you can see a pattern where, again, alertness and sustained attention and vigilance are definitely impacted in narcolepsy type 1, and the magnitude of that impairment is about the same between people with narcolepsy type 1 and people with IH. But we know there's other cognitive domains that are impacted in people with narcolepsy type 1. I think if we do the studies in IH, we're going to see something very similar. I think the cognitive impairment that goes along with these disorders really, again, contributes to the burden of disease. There's been some interesting data come out in what happens to IH over time. So what you were looking at here is from the Wisconsin sleep cohort, David Plant's group. They looked at the Wisconsin sleep cohort, which is state employees in Wisconsin, is a longitudinal study. The original population was enriched for people who had suspected sleep apnea. And then they tried to find within that population people who had IH. So they had to be sleepy. They had to have an Epworth of at least 11. They couldn't have another cause of sleepiness. So no sleep apnea, no sleep deprivation, no sedating medications, no medical conditions that cause sleepiness. And one of the great things about the Wisconsin sleep cohort is they have MSLTs. And so they also had to have a PSG MSLT meeting IH criteria. Within the Wisconsin sleep cohort, they found a prevalence of 1.5% for IH. That population is enriched for people with symptoms of OSA. So even though the IH patients didn't have OSA, maybe some people got into that because they were sleepy. Not for nothing, that is the same prevalence that Maurice O'Hoyen found for the DSM's hypersomnolence disorder, which is the DSM's equivalent of IH. Did a phone survey trying to get at symptoms of hypersomnolence and found also a population prevalence of 1.5%. But what I'm highlighting here is in the figure, they had, for those people with IH, they had Epworth scores over time. And you can see they're all over the map. They go in lots of different directions. They do not follow straight lines at all. Some people are normal at all but one time point. Some people become normal. Some people become worse. Lots of people fluctuate. And so when our IH patients ask us, what is the disease course going to look like? It's not obvious that we know the answer to tell them what it is. Another way of looking at how IH changes over time comes from Carl Sanka's group. They looked at a clinical series of 60 people who had been diagnosed with IH at least 3 years earlier. And on average, it had actually been 10 years earlier. And then they looked at the 2 time points to see what had happened. And so of those 60 people, 10 people, it just went away. They didn't have symptoms. They were not on medications. They were fine. 83% of people still had symptoms at follow-up. But what happened is not all of those people still had IH. So the biggest piece of pie were people who still had IH. A few people converted to narcolepsy type 2. Most of the people in the group didn't have another MSLT, so they didn't all have the opportunity to convert into a diagnosis of narcolepsy type 2. But there was this group that developed new diagnoses that might better explain the sleepiness or might additionally explain the sleepiness. So severe depression, bipolar disorder, severe medical issues, other severe sleep disorders. And so I think we have a bit of a chicken and an egg problem to know if these people have IH, had IH, or if it was always the other disease brewing. But I think the point is we all need to keep an index of suspicion for another disease developing over time. It's not like once you get the diagnosis of idiopathic hypersomnia, we'll never find something else that explains the sleepiness. So we have to keep an eye out for that. And then one other way of looking at changes in IH over time, the Hypersomnia Foundation has a patient registry that patients are encouraged to fill out every year. We are looking at data from 322 IH participants who filled it out at least twice, on average about 2.5 years between, and then looking at the symptoms over time. And the bad news is the symptoms don't change very much. So the The light blue here is people who had the same symptom at both time points. The green is people who didn't have substantial symptoms at each time point for the various measures. The two bars in the middle are people who developed it and people who recovered from it. So you sort of see most people it stays the same. A few people get better, a few people get worse. But for most people, the symptoms are not meaningfully changing over time, which is a problem because we're supposed to be trying to fix people's symptoms over time. So it suggests we're not doing that particularly well. These are patients from mostly the US, some international patients as well. The relationship between IH and mood disorders is perplexing and hard to disentangle. Someday when we have biomarkers, we'll be able to understand this, but for now, it's a lot of phenomenology. But this was a fascinating study of basically all the patients who underwent CSF testing as part of the workup for central disorders of hypersomnolence for almost a 20-year period. And then because the investigators were Danish and there is a Danish National Health Registry that keeps track of diagnoses, they were actually able to look at psychiatric diagnoses 10 years before the hypersomnia diagnosis. And then they matched people 1 to 4 with population controls. And what they found was people with IH are substantially more likely to have been diagnosed with a mood disorder 10 years before their IH diagnosis than people in the general population. We like to rely on temporality, right? The mood disorder came first and then the IH came second. And so the mood disorder caused sleepiness. I think we need to exercise extreme caution in doing that in this case because the average diagnostic delay in IH is more than 10 years. So I think it's actually possible the symptoms all started at the same time. Or certainly the symptoms can start at similar time points. I don't know that this is telling us anything necessarily about cause and effect, but it is certainly telling us something important about comorbidity burden. And interestingly, in that same study, they found a very similar relationship between mood disorders before the diagnosis of narcolepsy type 2, but not in narcolepsy type 1, which was somewhat in contrast to some earlier studies about mood disorders in narcolepsy. And then, of course, antidepressants, although they are great when people need them for mood disorders, many of them are sedating. This is from randomized controlled trials of adults with major depression. And you can see there is exactly one antidepressant that falls on the line of less sedating than placebo. It is bupropion. Everything else is either numerically or statistically more sedating than placebo. But I consult this chart a lot when I'm trying to figure out the least sedating antidepressants to recommend people take for their mood disorders. Pathophysiology, unfortunately, is not going to be a very long section of this talk. Someday it'll be a long part of my talk, but not yet. But there is some interesting new data on pathophysiology. So first, this is from Yves Devalier's group in France. They have a 32-hour enforced bed rest protocol that they use to evaluate people with IH, and they incorporated core body temperature measurement through an ingestible pill. And basically what they found was people with IH, people with subjective sleepiness with normal testing, it didn't have any difference in their circadian phase or their circadian amplitude compared to non-sleepy controls. And so there has been this question of, is there a circadian abnormality in people with IH? And now they have good data to say, if there is, it's not phase or amplitude. The caveat is this study design required them to assume that the period length is 24 hours. And prior work has suggested that people with IH may have a longer period length based on BMAL period length in skin fibroblasts in people with IH. So I think that is still an open question about circadian dysfunction in IH, but some really important negative data here otherwise. And then on the genetic side of things, some incremental progress as well. We think about 1/3 of people with IH have a first-degree family relative with excessive sleepiness and a few hints on what might be going on. So in terms of circadian genes, there are some decreased amplitude of expression of some circadian genes. There is a variant in PER3 that appears to be overrepresented in people with IH in a study of candidate sleep and circadian genes. There was a genome-wide association study of IH that did not find any SNPs with genome-wide significance, but it did find a intriguing possible candidate in PDE9A. There's one series of IH that in a small subgroup of the total IH population showed a missense variant in pre-pro orexin. There is a really intriguing mouse model, and that's what the data you're looking at from the figures are, with a splicing mutation in the SIC3 gene, and these mice sleep longer. They have a slower decay of delta during their active period, which might be an electrophysiologic marker of sleep inertia. And I don't know how you get a mouse to do an MSLT, but they have a shorter mean sleep latency on their little mouse MSLT. And so a potentially really convincing mouse model for IH. And then out in preprint, has not been peer reviewed yet, but is really intriguing. A study looking at flies and fish, and looking at this CAD-M2, it's a synaptic adhesion molecule that if you knock it down or if you get rid of it, you get sleepy flies and sleepy fish. And it is part of the neuropeptide Y system. And so potentially there's a human analog treatment target downstream from that. So more to come on that. This is an older study. This is almost a 10-year-old study now, but it's certainly one that has always impacted my thinking about IH, again, from Carl Sanka's group. This was a cluster analysis where they just threw all the symptoms and MSLT findings into a computer and said, hey, sort these people. And it sorted a good narcolepsy type 1 group. It sorted a good idiopathic hypersomnia with long sleep durations. And then everybody with IH with normal sleep and everybody with narcolepsy type 2 sorted into the same cluster. So there's been this idea for a long time that there's probably 2 IHs or at least 2 IHs. I'm not sure 2 will be enough. But there have been a few other cluster analyses recently that really, I think, add strength to this conclusion. So this was a study from the European Narcolepsy Network database where they looked at lots and lots of different clustering factors. And the orange red are narcolepsy type 2 and the green are IH. And you can see that almost all of the IH and narcolepsy type 2 patients fell into 2 different clusters, but the IH and the narcolepsy type 2 were intermixed in both of those 2 clusters. One of those clusters was driven by sleep inertia, memory problems, fatigue, and longer sleep length on the weekend. So more of an IH kind of cluster. But again, suggesting all the IH people are not falling into the cluster. There's probably at least 2 IHs. And then earlier this year, a different group looking at nocturnal sleep dynamics and what does the nocturnal PSG tell us on a cluster analysis, found also 2 clusters of IH patients, one being driven by more N3, less N2, higher sleep efficiency, things we think of as sort of more classic IH. And so probably at least 2 IHs if we knew how to define them. So I'm going to pivot and talk about treatment. I always like to start with non-pharmacologic strategies. I think our patients all want non-pharmacologic strategies. We don't know as much as we need to about what works and what does not work in this regard. Unlike people with narcolepsy type 1, who I often tell to take naps, naps are not usually helpful for people with IH, but school and work accommodations can be very helpful. So late start time to help with the sleep inertia, because they do have attention problems, the same kind of accommodations that kids with ADHD get, so more time on tests, breaks, and so on. And then I think support is really helpful. IH can be a lonely diagnosis because most people don't know anyone else who has it and in fact never heard of it until they got diagnosed with it. And so I think like with lots of diseases, it can be really helpful to have a patient community of people who understand. I think the Hypersomnia Foundation does great work. They will think of things to educate patients on that I won't think of to educate patients on. And so lots of resources on their website that I often send patients to. The bad news is patients don't find non-pharmacologic strategies to be that helpful. This was a questionnaire of IH and narcolepsy patients and asking people how much benefit they got from a variety of non-pharmacologic strategies. And generally, things got 2 or 3 out of a 10-point scale in the people with IH. So not exactly a robust response. Some data came out earlier this year, a registry study of more than 500 people with IH, and they asked them, did you get counseling about these various things, and what do you wish you had gotten counseling about? And these are the various things that people got counseled about. You can see most people aren't getting counseled about some of these things. Some of these things I'm not sure what we should say. It's unclear to me what we should counsel people about diet and exercise. It's unclear to me if we should be telling people to schedule naps. Probably not for the average IH patient, but surely everyone should be told about driving safety, and everybody who's on a relevant medicine about OCPs. And I think it's really interesting, especially, what do people wish we were telling them? What are the long-term effects of medicines? What are the drug interactions? Why you should sleep at least 7 hours, what the medication is going to do to sleep length and sleep quality, and what lifestyle changes they should be making. When I think about treatments for IH, I generally put them into 4 buckets. There's one FDA-approved medication, which is calcium, magnesium, sodium oxybate, which I will refer to from now on as lower sodium oxybate. There are 5 things in the ASM guideline for idiopathic hypersomnia that came out before lower sodium oxybate was available. Modafinil was the only one to get a strong recommendation, but there were conditional recommendations for methylphenidate, pitolisant, sodium oxybate, and clarithromycin. Usually what we are doing is taking medicines that are FDA approved for narcolepsy and using them off-label in IH. And then there are a handful of other medicines that we sometimes use in edge cases. Of course, the phase 3 randomized withdrawal trial of lower sodium oxybate for IH came out in 2022. Remember, everybody was on oxybates for several months. It was open label, and then people were randomized and blinded to either stay on lower sodium oxybate or suddenly stop it and change to placebo. And people were much worse when they suddenly changed to placebo in terms of their Epworth. But what is new is the long-term follow-up. So what you can see in the pictures is the Epworth on the top and the idiopathic hypersomnia severity scale on the bottom. The pre-randomization, the randomization, and then the open label extension. And you can see that people who stayed on the medication continued to experience a sustained benefit. 154 people took at least a first dose of lower sodium oxybate. Of those, 106 entered the open label extension and 95 finished it. So approximately 62% of people who started it were still taking it at the end of 40 weeks. There is a handful of data on stimulants for IH. I think we all presume they'll be helpful because they're helpful for lots of other causes of sleepiness. Not a lot of clinical data out there. We recently did a non-inferiority trial comparing amphetamine salts to modafinil. We didn't want to do a placebo-controlled study now that there are medicines that we know work, like modafinil. And so the idea is you have some people on modafinil, some on amphetamines, and you see if the amphetamines are not worse than modafinil. We found a similar magnitude of Epworth improvement with modafinil and with amphetamine, dextroamphetamine, 5 points and 4.4 points, but we did not statistically demonstrate non-inferiority. The confidence intervals were wide enough that we couldn't rule out that modafinil was better. However, amphetamine, dextroamphetamine was non-inferior to modafinil for cognitive dysfunction, for sleep inertia, for overall disease severity through the hypersomnia severity index. So some secondary outcomes showing non-inferiority. Our study had very strange safety outcomes compared to what I was expecting. We had a lot of dropouts in the modafinil group due to adverse events, many more than in the amphetamine group, which I would not say is typical of clinical practice, and certainly might have impacted these results somewhat. The ASM recommended pitolisant based on this clinical series from Isabel Arnulf group in France that showed about a third of people with refractory IH responded to pitolisant. Unfortunately, the phase 3 trial in the US showed no significant difference between pitolisant and placebo in the 4-week blinded withdrawal, at least based on their press release. So I can't tell you more data about that because I'm not privy to them, but it was a negative trial according to the press release. And so less enthusiastic about pitolisant for idiopathic hypersomnia after that. Given that we have a number of tools in the toolbox, how do we personalize treatment? I think it helps to consider what IH symptoms are most bothersome to the patient. Some of these we know how to target and some of them we don't. Of course, you want to look at the strength of the evidence when we have it. Medication interactions are important. Modafinil and armodafinil are strong inducers of 3A4. Pitolisant is a weak inducer of 3A4. This means all of these medicines will impact the efficacy of hormonal birth control. So it is really, really critical to talk to people about that so we don't accidentally make them pregnant. Several of the medicines we use can cause QT prolongation, and so that is important to keep in mind, especially for people who are also on other medicines like antidepressants that do it. I think taking people's comorbidities into consideration is really important from a side effect standpoint. What medicine are they going to tolerate if they have bad depression? What medicine are they going to tolerate if they have dysautonomia? Of course, insurance coverage, much as we wish that weren't the case, patient preferences, and then plans for childbearing and breastfeeding. We don't have enough data to say what drugs are most effective for sleepiness in IH because there aren't that many randomized controlled trials in IH. We do know in narcolepsy, if you do a network meta-analysis, you can look at the relative benefit of the medications that we have. And so that's what this is. This is a network meta-analysis of narcolepsy clinical trials. On the top, you see the Epworth, and on the bottom, you see the maintenance of wakefulness test. Solriamfetol, numerically the biggest benefit in both. And then you see for the Epworth modafinil, the oxybates, and then pitolisant, and similarly for the MWT armodafinil, modafinil, then the oxybates, and then pitolisant. Amphetamines aren't here because there aren't randomized control trials of amphetamines in narcolepsy to include. But not all of these medicines are equally potent in the treatment of sleepiness. Severe sleep inertia, I think, is a major problem for a lot of our patients. If we do find a wakefulness promoting medication that keeps them awake during the day, if they can't get awake enough to take it, it can still really impact their lives. And so what do you do when somebody has severe sleep inertia? There are several options. So lower sodium oxybate is definitely one if they are otherwise a good candidate for that medication. In the IH clinical trial, they used a visual analog of how easy was it to wake up in the morning. And when people were randomized to placebo after having been on lower sodium oxybate, their ability to wake up in the morning got 22 points worse on a 100-point scale. So a reasonable magnitude of worsening suggesting that lower sodium oxybate is helpful for sleep inertia. There's a long history of dosing medications at bedtime to help people wake up the next morning. Bedrick Roth, who described IH, recommended you do that with amphetamines in his early descriptions because that's all he had when he was writing those descriptions. There's a great case series from Carlos Schenk using bupropion extended at bedtime to help people wake up in the morning. I have had some good success with that, except for people who can't fall asleep on it because it's too alerting. Sometimes we use flumazenil for this. There is a form of methylphenidate that is a delayed extended release. It's absorbed in the colon. So you take it at night and it is not active. It doesn't start to release for 10 hours. And so instead of having something that's disrupting someone's sleep and being available in the morning, you can take something at night, have it not release until the morning and help people wake up. I've had some really good successes with that when I can get it covered. For the people who have a phase delay, phase shifting approaches can help. A trick I learned from one of my patients and subsequently learned that many of my patients have learned from other patients is this idea that if you have to wake up at 8, you should set an alarm for 7 and you should set an alarm for 8. When the 7 a.m. alarm goes off, you take your wake promoting medication and then you go immediately back to sleep. And then at 8, when your second alarm goes off, the medication is actually active in your system. And so it helps you to fight through the sleep inertia. I have lots of patients who do this. You have to be able to wake up enough when the first alarm goes off to swallow the pill, which not everybody can do. So we incorporated this into our modafinil Adderall clinical trial. We gave people the option of doing this timing. I was actually pretty disappointed that it was not that helpful. So much or very much improved sleep inertia was only about 20% for both medications, even with this strategy. So I don't think it's perfect by any stretch of the imagination, but for some people it can be helpful. This was a sort of quick and dirty table I put together of different IH treatments and different IH symptoms. If there is a bolded yes, we have a good randomized controlled trial that shows that this outcome gets better. So modafinil helps with driving safety, oxybates help with work and school performance, and so on. If there's a probably, there's a good clinical series or a smaller study that suggests that there's reason to believe it will be helpful. And if it says sometimes, it means exactly that. There does seem to be a subgroup of IH patients who in clinical series respond on this measure. Again, what you see on this table is a lot of blank spaces. There's a lot we don't know about which medicines are best for what. And then what to do about pregnancy and conception is the subject of a much longer talk, but I think it's really important based on the demographics of our patient population to have this on our radar. I know I have colleagues who say you should never take medicines for sleepiness during pregnancy, period, hard stop. I take a more holistic approach to say that every risk is balanced by another risk. And so you're not just trying to minimize the risk of medication, you're trying to minimize the risk of sleepiness. So getting into a car accident because you fell asleep at the wheel while you were pregnant is also very bad for pregnancy outcomes. Getting fired from your job while pregnant because you're too sleepy is very bad for pregnancy outcomes. And so I think this balance is really important. Some women will choose not to take medicine during pregnancy, and some women will have to take medicine during pregnancy. And that is, I think, the reality of it. What do we know about medications in pregnancy? Of course, not enough. Of the oxybates, animal data suggest potentially some harm. There's really not enough human data to know. What we do know for sure is you should stay away from modafinil and armodafinil. This is really different than a few years ago when we thought maybe they were the safest. The data are mixed, but now there are several lines of evidence showing an increased risk. So the US registry data shows a 13% rate of major congenital malformations versus the 3% baseline risk. There is similarly a study from Europe that showed a 3 times higher risk of fetal malformations with modafinil than with no medication, but also with modafinil versus methylphenidate. Modafinil was 3 times more likely to cause or be associated with fetal malformations than methylphenidate. Methylphenidate was not higher than controls in that particular study. This is another area where the Hypersomnia Foundation is a great resource. They have links to all the studies of all the medications on their website. And so I send patients to it a lot. I send colleagues to it a lot. If you really want to dig into the safety profile and what we know, what we don't know, that's a great resource. More broadly, I think it can be helpful for people who are thinking about what to do when they get pregnant but aren't pregnant yet to undergo a preconception visit with OB or with MFM. As sleep doctors, I think we see pregnancy so rarely that we are very scared of medications, but OBs are used to women taking all kinds of things during pregnancy. And so I think they bring a balance in terms of that risk versus benefit. I think their perspective is helpful on that. Also remember that if your patients have accommodations, they might need to change during pregnancy, or if they don't have accommodations, they might need to start. You can also try to time medications during preconception based on when the medication is going to be a risk and when the medication is not going to be a risk. For women who don't get pregnant right away, who think they're going to be trying to get pregnant for a long time, this can be a good strategy. And again, the details are at the Hypersomnia Foundation site. Back to the Hypersomnia Foundation registry, we asked people, have you tried this medication? Never tried it. If you're still on it, and so on. And basically, for all the medicines that at least 50 people had taken, there was not a single medication that more than half of people were still taking at the end of the registry. So more likely than not, anyone who starts a medicine for IH will have stopped it by their final registry visit. So this suggests we have a long way to go in terms of treatment. when somebody has treatment refractory IH, I always take a step back and think, are there other diagnoses I'm missing, or are there comorbidities that if we manage the comorbidity, we can decrease the overall burden of disease and help our patients be more functional? We use lots of combination therapy. We use clarithromycin and flumazenil, generally only in treatment refractory cases. And then, the pipeline for IH was empty for a really long time. So it's nice that there are things in the pipeline now. Once nightly sodium oxybate is enrolling for IH. Excuse me, the serdexmethylphenidate IH study recently completed. Those data aren't available yet. This is another form of dexmethylphenidate, where you have a delay in when the concentration of the drug starts to rise. So it might have some interesting effects in people with sleep inertia. And the hypocretin receptor agonists, of course, we were all excited about for narcolepsy. None are currently enrolling for IH, but of course there was a trial, a one-day IV study of danovarexetin in IH patients that showed a similar magnitude of benefit to what we see in narcolepsy type 1. So hopefully those are going to be coming. So with that, I thank you so much for your attention, and I'm happy to take any questions.
Sorry about that. Thank you so much, Dr. Trotti, for this fantastic and very informative updates and refresher on this very relevant topic. And special thanks for an excellent talk on a day like this. With this, I will open up for questions. And the first question I have is from Dr. Clara Yagi. Excellent talk, Lynn. Does the normal circadian phase and amplitude study, I think that you showed, suggest IH is predominantly a homeostatic sleep drive issue? It seems unlikely to be driven only by adenosine accumulation. Could Emery's data about a factor in the CSF stimulating the GABA receptors explain this? You didn't mention this in the mechanism section. Is this still a plausible mechanism to be explored? Clinically, I'm still using flumazenil and clarithromycin with some efficacy.
Yeah, me too. So good to hear that. There certainly seems to be a subgroup of people who respond to those medicines, but not everybody. Yeah, I mean, I don't think we have enough data yet to say it's definitely not circadian or it's definitely homeostatic, but certainly we're starting to rule out a number of the circadian issues, although, that PER3 gene abnormality was the same group. So I don't know that we're totally done with the circadian part of the story. Yes, we are still actively exploring the GABA hypothesis. I don't quite have the new data to show on that, so I didn't say anything new about that. But yes, that is still under investigation here.
Thank you. Next question is from Dr. Junji Liu at University of Iowa. Well, first question, how is the 11-hour time cutoff in the IH diagnosis criteria established? Is it sensitive and specific enough compared to MSLT? And the second one is, in my clinical practice, many patients complain of medications losing effect after a while. Is there research guiding how to treat when tachyphylaxis happen? For example, rotation across drugs or take drug holidays? Thank you.
Yeah. So the 11-hour cutoff comes from Isabel Arnold's data, where they had people sleep overnight, take a nap as long as they wanted in the morning, and take a nap as long as they wanted in the afternoon. And 11 hours was the cutoff that best distinguished IH patients diagnosed clinically from controls. In their population, most of the people who met the 11-hour criteria and clinically looked like IH had a normal MSLT. So 71% of their people who slept at least 11 hours and had clinical IH had a normal MSLT. So more likely than not, the long sleep and the short mean sleep latency did not go together. Yves Duvalier subsequently published from his 32-hour bed rest protocol in the first 24 hours, actually 12 hours of forced bed rest is a better cutoff is their best cutoff between patients and controls. He found the opposite of Dr. Arnold, which is the people who slept the most on the long sleep protocol also had the shortest MSLT. So I don't know how to reconcile those two things. That is still an open question. But it is an evidence-based 11-hour cutoff. I totally agree. This problem of medication tolerance is hard. I'm not aware of good data on how we should manage that. I use a variety of strategies. I have lots of patients who take drug holidays, especially on the weekends. It is really hard because when somebody with IH who's on wake promoting medications takes a drug holiday, they sleep the whole day, right? You're really giving away your weekend to sleep. And so people have to do it, but it is not an easy thing to do. Sometimes people will use a different medication on their drug holiday or alternate between two classes of medications if they're lucky enough to have two classes of medications that are helpful. I have people do both strategies. I think it's more driven at this point by what is most tolerable to the patient.
And is the drug holiday for a day or two, or how do you do it?
I would say the majority of my patients who take drug holidays take them 2 days in a row. So they lose their whole weekend. And partly that's because that's how society is structured to allow a drug holiday. I have some people that it is not enough. So like I have people who have to take a whole week off every month, and then they sort of plan their whole lives around not doing anything that week.
Thank you. It's 3:01. We still have a few more questions. So if people have to leave, please feel free. Dr. Trotti will answer the questions. Next question is from Dr. Samia Ayub. Thank you for this terrific talk. Question with regards to Epworth scale. Oftentimes the score is highly variable at different times of the day, and we ask patients to give average. If asked to specify what time of the day would you say to ask it?
Yeah, I mean, I think you're right. I think the best is to say the average because it's not supposed to be one time of day. You're supposed to be capturing in recent times sort of globally. And so I always tell, when people say, well, do you mean at night? Do you mean during the day? I always say average it across all times of your day.
Thank you. And this is from Dr. Brian Koo. Hi, Brian. Hi, Lynn, Mary. Thank you for your excellent talk. You touched on IH phenotypes. Can you comment on how many common IH phenotypes do you think that there are and what they are? Thank you.
Yeah, I mean, I don't know the answer to that question. I do think this idea that the people with long sleep and the people with normal sleep durations are meaningfully different. They're easier to measure. Like that's one way you can separate them out. But more than that, there's a number of groups that have shown that people with the longer sleep durations also have more severe sleep inertia. They tend to have more severe symptoms. Like that may turn out to be a meaningful dimension. And I think some of those cluster analysis studies that I showed kind of capture that because it's sort of looking at the classic IH phenotype seems different than the normal sleepers, less sleep inertia, less good sleep efficiency. What I wonder about though is if 2 is not going to be enough. I'm not sure that's the only dimension that matters. I think there's a group of people with IH who have dysautonomia and they meet criteria for chronic fatigue in addition to meeting criteria for IH. And some of them have fibromyalgia, and some of them have, these diagnoses that tend to cluster together, MCAS. I don't know if that dysautonomia group is really going to be the same as everybody else with IH, or if that's going to turn out to be a separate phenotype. We see that in narcolepsy type 2. We see that in narcolepsy type 1. But I think that might turn out to be an important subgroup as well.
Thank you. Next question is from Adrian. Thank you for this excellent talk. Do you have any experience with baclofen for sleep inertia in refractory cases?
Yeah, I have a handful of people on baclofen. The idea with baclofen, for other folks on the call who may not be aware is, oxybates are GHB agonists and GABA B agonists. Baclofen is a GABA B agonist. And so early in the development of sodium oxybate, there was some interest in baclofen as a cheaper alternative. The data from back then suggest it also improves sleep quality and increases deep sleep in people with narcolepsy type 1, but didn't really help with sleepiness the way oxybates do. But I have a handful of people with IH or other hypersomnia disorders who can't get oxybates or don't tolerate oxybates, or otherwise we want to try to help with the nighttime sleep, and oxybates aren't a choice. Um, I, I have mixed success with it, I would say. I try it from time to time. I don't have a ton of patients on it.
What's the dose that you use for?
I usually start at 10 milligrams at bedtime, and then I increase by 10 milligrams once a week up to 40 milligrams. I made that dosing up based on the package insert, which is not for this indication. So I don't have any evidence for that. That just felt like the best modification I could come up with.
Got it. Thank you. And I think this is the last question in the chat room. Hi, this is Max Liu, a fellow at WashU. In people doing the 11-hour TST, do we need to wean them off the SSRI and other psychotropic meds? I find this the biggest hurdle in getting an accurate diagnosis.
Agreed. I think the REM suppressant medications are a major hurdle in the way we do the diagnosis, especially if like people have an odds ratio of 3 of having had a mood disorder diagnosed before their IH is diagnosed. It's a real problem. I think the answer is it depends. Lots of antidepressants are sedating. And so like if somebody is on duloxetine and they're really sleepy, like I'm not sure I want to put them in for an 11-hour PSG, because how am I going to know that it's not their duloxetine that's making them so sleepy? So even if I don't care about REM, I still care about the sedating properties of the antidepressants. But separate from that, the reason that we do our hypersomnia PSG MSLT protocol the way that we do it, instead of just doing a 24-hour PSG, is one, we have to, because then you can bill for the PSG and the MSLT, right? And then our techs get paid, and that's good. But the other reason that we do it is the reality of the world we live in is it is much better to have narcolepsy type 2 than to have IH. Even though we're not sure those two things are different, you have this many medicines that are FDA approved if you have 2 SORAMs, and you have this many medicines if you have 1 SORAM. So I actually think even if you think somebody's going to sleep for 11 hours, you absolutely still want to do the MSLT to give them the opportunity to have SORAMs. And so if you can safely get them off their antidepressant, their REM suppressant, I still think it's worth doing, because those SORAMs mean so much in terms of medication access, even though they shouldn't.
Yeah. Thank you. And along those lines, do you guys usually do the 7 days, the actigraphy, and is that covered by insurance?
Yes, we do it. No, it is not. So we write it off because it's so helpful in understanding what's going on with the patient. But that is obviously a privilege to be able, right? Like I don't think most sleep providers out in private practice can do that, but it's really helpful.
Yeah, and that would also not give you the SORAMs. So
The ASM is advocating to try to improve coverage for actigraphy. So if they're successful, I think that would make life easier for all of us.
yeah, especially for people who can't sleep in the lab. So
Yeah.
great. Any other questions? I don't see any. I think we're done. Thank you so much for talking today. It's an excellent talk, and thank you for answering all these questions. I didn't expect this many today, but thank you so much. Again, thanks so much for accepting this invitation and talking to us. Great.
Thanks so much for having me. Take
Thank
care.
you, everyone. Take care.